I invite Dr. Resmi Bhaskar, who is a senior pediatric ophthalmologist from Chaitanya Trivandrum, to enlighten us on the infrastructure and workflow of myopia clinic.
Good afternoon. My topic is setting the foundation, infrastructure and workflow for myopia clinic. So, Dr. Anila has given a detail regarding why you need a myopia clinic. If myopia children are forming a part of your major clinical practice, it is better you have a specialty practice and a clinic allotted for that. The need for it is for the prevention, early detection and management of myopia progression. Regarding it is better, you need a separate room or you can take it as a part of your clinic and it should be near your consultation room. You can give a name to the clinic, plan a logo, and if you have a busy OP, you can plan a fixed day. You ask all the myopic patients to come on a separate day so that counseling part you can give together. And you have to fix up to what age you are seeing the patient in the myopia clinic and what will be the exit age for them. And whether you want to give it as a full myopia service or as a limited option. When you are giving it as a separate clinic or a room, the importance is the patient awareness will be better, and even your colleagues, it will be treated as a separate entity. So there should be a clinical board which should be highlighted. So seeing the clinic's name, even the patients who come for cataract and all, their grandchildren might be having myopia, they will be aware about it. And patient education material should be displayed well. And refraction, biometry, counseling, the parents as well as the children, everything will be done in the same room. That will help in the time management also. So now coming to the workflow in the myopia clinic. First part is identifying the patient. Then you enroll them in the myopia clinic, profiling, myopia workup, the recommendation, and then from the recommendation part, they will again go to the counseling. From there, either will go to the glass, drops, or myopia contact lens clinic, whichever is suited for the patient. So, who are the patients who should be enrolled in the myopia clinic? All myopes after cycloplegic refraction. You can label them as myopia only after a cycloplegic refraction because we are seeing a lot of pseudomyopes also nowadays. All those are already wearing glasses are a non-myope. They can also go directly to the myopia clinic. Pre-myopes or those who have a risk for myopia, that is when they have a less than 0.5 refraction, and children of myopic parents. Now you enroll them in the clinic, you have to keep a register for that so that you can get the details regarding that patients and it will be recordable. You can also keep a WhatsApp support group if you want so that if they have any queries or things, they can interact among themselves also. Now, we just give a set of questionnaires to the parents regarding the age and history of ocular complaints, whether history of prematurity, developmental milestones, systemic conditions, if any, drug allergy, family history of refractive error of the parents, siblings, amount of myopia they have, age of onset of refractive error for the parents or siblings. Now the questionnaire regarding the visual environment, that is amount of time spent outdoors, amount of near work, type of near activities, digital screen duration, type of digital screen use, lighting condition at school and home. And if they are already using glasses, age of onset, first prescription, present glass power, the duration of the present glass, history of progression, that is the frequency of change of glass, or previous myopia control treatment if they are taking, where they are compliant with the drops or the glasses they are wearing. All this will help you in evaluating the patient whether they have chance for progression as well as what are the recommendations that we should be giving to them. So must do thing are the basic evaluation like the visual acuity, IOP, slit lamp and cycloplegic refraction. Dilated fundus is also a compulsory, binocular vision assessment and PMT in needed cases. Axial length and keratometry is also a must nowadays because you will get an evidence for the axial length prolongation if you are checking the axial length. If the axial length is normal and if there is a progression, you have to rethink whether it's a part of pseudomyopia also because whatever the myopia control measures we are looking it is mainly effective in controlling the axial length progression. So other things that are doing a peripheral refraction. But if open field autorefractor is not available also, you can ask the patient to look in the 20 degree sideways and check the periphery. You see whether it is a hyperopic thing. That also will helpful in dispensing peripheral hyperopic defocus glasses. MEM retinoscopy, the MEM retinoscope can be used to find out whether the patient is having a lead or lag of accommodation. NPA, NPC accommodation facility, corneal topography in indicated cases and tear film assessment. All these you can have a judgment regarding whether you need for that patient or not. Other tests include the pupillometry, especially if you are planning for a low dose atropine, serum vitamin D level because it has an association with myopia, aberrometry to find out the higher order aberrations, and macular OCT also in indicated cases. The following new myometers are now available. Has become, many companies are giving up new myometers. Myopia Master, which measures refraction, axial length, K reading. It do the data analysis, risk identification, generate reports. So it will give us a visual aid for the parents. So if you show them how the myopia is going to progress, it also track the axial length growth also. The OBM 12 measures 12 parameters in addition to axial length, AC depth, lens thickness, ECT, K value, white width pressure, white distance, pupil diameter, corneal diameter, vitreous depth, aqueous depth, and diameter of cornea. So Maya also detection and quantification of myopic ocular growth, which also assess the risk of myopia progression. Fundus evaluation is a must in all cases of myopes. As you can see, peripheral degenerations and documentation is also very important nowadays. So if there is, all these children may have peripheral retinal degenerations. So fundus evaluation and documentation is also very important. Coming after, once you have the diagnosis from the myopia clinic, they come back to you. So you discuss with the parents regarding the condition, the progression, how is the myopia status, and evaluate the risk for progression. Like early age, increased screen time, low outdoor time, and strong family history, they are always have a risk of high progression. And what are the lifestyle changes needed? That has to be explained in detail to the parents. Risk factor identification, as Dr. Anila has told, various myopia calculators are available. They will give you an idea. You can easily assess in the Google. The BHBI myopia, if you give the age and the dioptric power, they will give you a graph that what will be the expected myopic change when the child is at 17 years. If you are using a low dose atropine, what will be the myopic progression likelihood? You can show that to the parents and counsel them regarding it. You create a myopia control plan in discussion with the parents and select the preferred treatment for the child. You discuss about the cost, effectiveness, and side effects of each. It can be either be glass, contact lens, low dose atropine, ortho-K, or myopia control glasses, depending upon each child's need. Counseling, detailed counseling regarding the lifestyle modification, reducing the screen time, outdoor activities, and balanced diet. Everything has to be told in detail to the bystanders and children. So if a new patient is coming to the myopia clinic, you do a basic evaluation, cycloplegic refraction fundus in the first visit. And when they are coming for PMT, you can give them the questionnaire, axial length, myopia workup, and give the final recommendation. If it is a follow-up patient, they can go directly to the myopia clinic and do the basic evaluation, axial length, and see how the compliance of the already given treatment, whether the lifestyle modification they are strictly adhering to what we have told them, and the myopia control measures, whether they are following up, and you can rechange it or continue with the same control measure as per how they are doing. And follow-up, regarding the follow-up schedule, they have to be counseled regarding the strict follow-up schedule also. If you are planning low dose atropine, I usually call them back after 1 month to see how they are using it and whether they have any difficulty, how much is a pupillary dilatation, whether they are compliant with it. And contact lenses accordingly you can give. If there is a rapid progression, you call them usually after 3 months. And if they are regular normal follow-up with spectacles, you do 6 monthly follow-up, and a comprehensive checkup is to be done annually. So from the myopia clinic, the patient will go either to the pharmacy, opticals and contact lens clinic. As like how to ensure the proper working, hold regular meeting with the team members. Team members include ophthalmologists, optometrists, and counselors if needed. And give them training. Whenever new changes happen, you call them in a monthly or 2 monthly base and give them proper training how they are doing. Ensure proper documentation by verifying the records. You can give patient educational videos, and continuous monitoring is also needed. How will you add on to the clinic? You can do a school screening by which you can increase the number of patients, and kids of LASIK patients also you can screen them. All siblings of myop you can do an early screening so that you will have an early detection. Thank you.